Hi everyone, my name is Naidoo², a medical scientist at the KwaZulu-Natal Research, Innovation and Sequencing Platform in Durban, South Africa. It is my pleasure to briefly summarize the e-poster entitled Low-Frequency Integrase Drug-Resistant Mutations in People with Virological Failure on dolutegravir-based antiretroviral therapy, on behalf of the DTG-Resist study group. The DTG-Resist study is a multi-regional observational cohort nested within IDEA. As we know, next-generation sequencing is increasingly replacing Sanger sequencing for many pathogen genomics applications. It is therefore important that we understand the frequency and clinical significance of low-frequency mutations to inform the potential transition to the routine use of next-generation sequencing for HIV drug resistance testing. Given the wide-scale global transition to INSTI-based antiretroviral therapy, this study focuses specifically on INSTI resistance. To conduct the analysis, 341 specimens with virological failure from 18 sites across sub-Saharan Africa were sequenced and analyzed. 324 paired NGS and Sanger sequences were available, and drug resistance was interpreted using HydraWeb and the Stanford HIV database algorithm. Major INSTI mutations were detected in 90 or 28% of sequences, with the most frequently detected major INSTI mutations being E138K, G118R, and R263K. Analysis of the sequences revealed 19 cases in which low-frequency mutations were detected by NGS. These are summarized on screen with the low-frequency mutations indicated in red. Of these 19 cases with low-frequency mutations, 3 resulted in changes to predicted drug susceptibility. These are highlighted in blue in the table and detailed further in the following slide. Case 1 is a 27-year-old treatment-experienced female from Zimbabwe with persistent virological non-suppression on TLD. The N155H major INSTI drug resistance mutation was detected at a frequency of 6% and was accompanied by a number of NNRTI and NRTI mutations as displayed on the table. Case 2 is a 38-year-old treatment-experienced female from Malawi with persistent virological non-suppression on ABC, 3TC, and DTG. Here, the R263K major INSTI drug resistance mutation was detected at a frequency of 10% and was accompanied by NNRTI and other RT mutations. Our assumptions in case 1 and 2 are that the low-frequency mutations are emerging drug resistance mutations due to treatment failure. Case 2 may also be an example of differential adherence. Case 3 is a 56-year-old treatment-experienced male from Zambia with persistent virological non-suppression. This patient had previous confirmed virological failure on TLD. G118R, E138A, and R263K major INSTI mutations were detected at a frequency of 12, 16, and 35% respectively, accompanied by accessory and other INSTI mutations as well as NNRTI and NRTI mutations. The G118R and E138A drug resistance mutations had previously been detected by Sanger sequencing 8 months prior at the time of TLD failure. Case 3 is a complicated multiple enrollment case. From the prior Sanger sequencing at the time of TLD treatment failure, we know that the low-frequency mutations detected were previously in the majority population and are now in the process of reversion. We assume this is as a result of reduced drug pressure, most likely due to poorer adherence. From our findings, we are able to conclude that while Sanger sequencing is efficient for drug resistance testing, next-generation sequencing does have potential added value, particularly in regard to detecting emerging drug resistance and the reversion of drug resistance. Finally, I would like to acknowledge the contributing authors and affiliated centers. I hope you have found the study informative, and thank you for your time.